Uh, Good morning, everyone. Welcome to yet another edition of ISG Masterclass. Last time we had a discussion on chronic pancreatitis, and the lecture was given by Dr. Manu Tandon, and it was a wonderful lecture. Today we are moving to one other module on masterclass, and as I discussed with you all last week, that we are going to start a series of 7 masterclasses on GI cancer. And in that series, we have the first talk today, that's on GI lymphoma. And we believe that GI lymphoma is an important part and parcel of gastroenterologist practice. And as we know that all GI cancer are they require multimodality approach. They require multidisciplinary collaboration for appropriate treatment of the cancer. And we also know that in our country, we don't have very well-oiled system for treating uh, uh, all cancers because they only have some institutions who have run tumor boards. Otherwise, many patients of cancers are treated on individual basis. While we know that most cancer will require a collaboration between multiple specialists in the oncology. So coming back to today's talk, it's a gastrointestinal lymphoma, and this talk will be talk plus panel discussion will be moderated by Dr. K. M. Mohandas, which is very popular amongst all gastroenterologists, and he had been at Tata Memorial Center in Mumbai, and for last about 10 years he is in Tata Medical Center in Kolkata, and he heads Department of Digestive Diseases at Tata Medical Center in Kolkata. So he will first speak to us on GI lymphoma, an overview, and then lead the panel discussion. For this panel, we have again a very esteemed panelist, starting with Dr. Prachi Patil. She is at Tata Memorial Center in Mumbai. She is again a professor in Department of Gastrointestinal Sciences. We have Dr. Naveen Khattry, again from Naveen Khattry is a medical oncologist. He's a professor at Tata Memorial Center in Mumbai, and he was trained earlier at AIMS. And we have a third panelist, Dr. Rimpa Basu. She is a radiation oncology senior consultant at Tata Medical Center. With this, I request Dr. Saraswat to welcome you all, and then we go to talk and panel discussion. Dr. Saraswat, please.
Thank you, Govind. Good morning to all the participants and a warm welcome to this edition of the ISG as Professor Makharia has just told you, we have been doing single topic master classes so far for the last 4 months, almost 24 of them. I believe this is probably the 25th session that we are hosting. And we thought that now we would have a slight change in the format and move to more panel discussions and focus on the area of GI oncology, gastrointestinal cancers. As you all know, in the last couple of decades, there have been huge advances in most areas of medicine and gastroenterology, but particularly so in oncology, as also in hepatology and gastro-GI imaging, and so on. So we seem to be now at a point in the evolution of the super specialty of gastroenterology at which the specialty of medicine was somewhere in the 1960s. That is, it is now poised from gastroenterology appears to be more like a broad specialty like medicine, and which is now leading to specializations branching out. We already had the pediatric gastroenterologist branch out quite a while ago, about 2 decades or so ago. Hepatology, which has branched out from gastroenterology, is a very flourishing field in its own right. And similarly, advanced GI endoscopy, different endoscopic techniques, US-based third space endoscopy, digital imaging, etc., are coming up in such a big way that they almost become specialities in their own right. And very much in this mix, we now have GI oncology. All of us are familiar with medical oncology, which is a rapidly growing department, and large number of departments of medical oncology in the public and the private sector have come up in the last decade or so. And well, it's probably about time that we qualified DM, DNB gastroenterologists started looking at a career and a future in GI oncology, not just the basics, the diagnostic and the palliative part, but the entire gamut of GI oncology. So with these few words, we thought it would be an opportune time to have a discussion on GI oncology. And for today's session, as Professor Makhari has already introduced a very distinguished and an esteemed panel, led by Professor K. Mohandas, who's probably not be wrong to say that he is the dean of the budding specialty of GI oncology in this country, a very well known and a highly reputed name in GI oncology. With these few words, I now invite Professor Mohandas to initiate today's discussion on GI lymphoma. Professor Mohandas, please.
I cannot see the. The slides have come.
Yes, sir.
Okay. Good afternoon to everyone. And also, being a Malayali, I would like to wish all of you a happy Onam. In COVID times, things are a bit difficult. So without any further delay, I would like to get on to the initial introductory talk on GI lymphomas. So, see, this was my first gastroenterology paper that I read at ISG in 1987, 33 years ago. And it was on primary gastric lymphomas. And in that, we had concluded that primary gastric lymphomas are not uncommon. Endoscopic biopsies are very useful. Accurate preoperative staging is needed to avoid unnecessary surgery, and multimodality treatment is likely to result in best results. So let us see how things have changed in the next 33 years that has followed. So regarding the pathogenesis of lymphomas are a heterogeneous group of neoplasms that arise in the lymphoid tissues. So we have lymph nodes in the abdomen, which are mostly in relation to the large and the small bowel, and of course, esophagus and stomach as well. In addition to that, there are lymphoid tissue in the Peyer's patches of large and small bowel, and the stomach, which is generally devoid of lymphoid follicles, go on to develop lymphoid follicles when infected with H. pylori for a long time. So this is an acquired malt in the stomach, Peyer's patches, lymph nodes in the abdomen. All of these are potential sites for the development of lymphomas of the GI tract. How does cancer develop in general? There are three sequential hits that happens to driver genes. These driver genes are either oncogenes or tumor suppressor genes, and that finally results in malignant transformations. These hits may be random, happening as the person is growing old, or it may be caused by environmental factors like viral infection or pesticides and such things for lymphomas. And in a few cases, they are inherited. So you have the normal epithelium, there is a first hit, then you get a clone with just one hit. There is a hit in that clone resulting in a second hit and a third hit, and then finally there is malignant transformation. As far as the GI lymphomas are concerned, depending on the type of the GI lymphomas, there are a large number of translocations that are associated. You need not go into the details, but I've just listed here malt, mantle, follicular, anaplastic. Each of these are frequently associated with various translocations. So if we look for a little more details, Helicobacter pylori, which is so common all over the world as well as in India, it causes a chronic infection in a large majority of patients. And more commonly, it causes gastric adenocarcinoma. So we will forget that for the time being. In a small proportion of patients, the acquired malt that develops in the stomach, as I told you just now, undergoes various hits, and there is carcinogenesis triggered in that, resulting in a malt lymphoma. This malt lymphoma, the vast majority, 2/3 are H. pylori dependent in the very early stage. So if you eradicate H. pylori at this stage, you can cause regression of this malt lymphoma, and the patient will not progress to more higher grades. However, further hits can result in the malt lymphoma becoming H. pylori independent, and finally it can be transformed into a more higher grade lymphoma like a DLBCL. A smaller percentage, one quarter of the patients develop the same malt lymphomas, but these are to begin with H. pylori independent, and therefore even if you eradicate the H. pylori, these lymphomas are likely to progress and get transformed in the long run. What is the burden of lymphomas in general and GI lymphomas in particular in our country? In general, there is an increase in the incidence of lymphomas in India, but the survival in India is very poor. So just to take a global snapshot, this is in the US, there are about 13 cases per lakh population, new cases of lymphomas. And in India, there is about 2 cases. So you can see 6-fold higher in US as compared to India. But if you look at the mortality, you see in US, the mortality is just about 20% of this 12 per lakh, whereas in India, it is 82%. That is, we have a 4 times higher mortality from various lymphomas in this country. For various reasons, we diagnose them late, we don't treat them properly, and many don't get even treated, and so there are various reasons for that. This is an epidemiology paper on lymphomas we published a few years ago in oncology. Basically, the lymphomas have been rising in India as it has been rising in other parts of the world. But if you look at the mortality patterns, you can see that the mortality, the 5-year survival is low. It's less than 40% in most parts of India. In Mumbai, it is 35%. Whereas if you look at other Asian countries, Shanghai, Singapore, Hong Kong, etc., Korea, etc., you can see it's going all the way up to 65, 70 patients are surviving for 5 years. Lymphomas are of very many types, and over the last 30 years, the subtyping has changed many times. So now it is mandatory to use immunohistochemistry, cytogenetics, flow cytometry techniques, as well as next-gen sequencing for subtyping. In 2016, the WHO published the revised classification. So chapter 13 is B-cell lymphomas. There are about 32 subtypes, and then there is a T-cell lymphomas, which are about 20 subtypes. So you can see 50 plus subtypes of various types of lymphomas. And these are basically dependent on the stage of evolution of the B cells. So, the mature B cell lymphomas are the ones that we are talking about. If it's because as they become leukemias and more advanced plasma cells, they result in myeloma. So CD20 is something that is present in all our lymphoma, B-cell lymphomas, and that is extensively used for, classifying. Similarly, with the T cells, we are talking about mature thymocyte and mature T-cell derived lymphomas. And here again, CD3 is something that is present in these lymphomas, and they are used to identify T-cell lymphomas. So in general, 90% of GI lymphomas are B-cell and 10% are T-cell. And these are some various immunohistochemistry plots. You can see ISG is mandatory. So as gastroenterologists, we must remember that tissues will be subjected to many cuts and slices and so on and so forth. And therefore, we must provide adequate samples for these when these patients come to us for endoscopy and not just take 2-3 biopsies and send them away. So in general, although there are 50 plus subtypes, this is a Greek and a German study for GI lymphomas. You can see that the diffuse large B-cell lymphoma is the commonest, which makes up about 50% of all GI lymphomas. Some of them are with MALT, some are without MALT. I discussed this before. Then you have marked lymphomas of the marginal zone. They make up about 45-48%. This is somewhat less in our country because we diagnose them much later. And many of these are picked up during screening endoscopies which go on in these countries. So they have many more marked lymphomas. Then we have T-cell lymphomas which make up a very small percentage of the GI lymphomas. So we have looked at the first 5 years at Tata Medical Center in Kolkata, looking just only at the large cell DLBCL lymphomas. There were, out of the 600 plus, 300 were in the GI. No, they were extranodal. 123 were in the GI tract. So GI is the most common extranodal site for non-Hodgkin's lymphomas. Within the GI, you can see again the distribution. Stomach is the commonest, 46%, followed by the small bowel, followed by the large bowel. And look at the staging. Just 1/3 of the patients were in stage 1 and 2, which are truly GI lymphomas. And 2/3 of the patients were stage 3 and 4. That meant they were diagnosed at a much more advanced stage. And some purists believe that these are not to be classified as GI lymphomas because they may be nodal, which has spread to the GI tract. So within the GI tract, gastric is the commonest, followed by large and small bowel. This is a very good paper, and I would recommend all of you to read this. This is a 10 years experience from CMC Vellore. And here you see that the diffuse large B-cell DLBCL is the commonest, followed by the MALT type. And they had a fairly large number of Burkitt's type. But you can see that, the ipsid and mantle cell and T cell, these are all very, very rare, even in India. So the common ones, if one were to look in the stomach, DLBCL was the commonest, followed by MALT, followed by Burkitt's. In small intestine, DLBCL was again the commonest, followed by Burkitt's, MALT. These are the T-cell lymphomas, post-transplant lymphomas, ipsid. So they all make up a very small percentage. And similarly, in case of colon. What is the presentation of GI lymphoma? They are great masculinals with many non-specific symptoms. This again is a very good paper for all of you to read. It is by Imon Kogli. I think many of us have heard his talks. He's been a regular visitor to India, published recently in BMJ Open Gastroenterology. They looked at 16 cases, consecutive cases of GI lymphomas that they came to the center in Texas, Houston. And you can see the symptoms: dyspepsia, diarrhea, obstruction, pain, bleeding, pain, ascites, anemia. So, they could present with any of these symptoms. And endoscopically, there were polyps, there were ulcers, there was infiltration, there was mass, there was obstruction, just mucosal changes. So, in other words, clinical appearance, clinical symptoms, and endoscopic appearances are very, very wide in case of GI lymphomas. But one of the consistent features which we have found in our country is that many of these patients have severe, moderate to severe malnutrition and cachexia. And patients who are malnourished and cachectic have less complete response to treatment and have more complications and death during treatments, obviously because of their malnutrition. And their long-term survival also is markedly reduced. So the gastroenterologists who are diagnosing these patients should also look at their nutritional status and start nutritional therapy for them from day one instead of waiting for things to worsen and they are referred back to them for giving nutritional support. How do we make the diagnosis? Because of the very varied symptomatology and appearance, the diagnosis is made incidentally. So be prepared. This is an old paper which we had done many 20 years ago comparing gastric lymphoma and carcinoma in 56 and 120 patients. And we found all kinds of appearances of the tumors. And the only consistent thing was the volcano crater. This is it. It is a protruding tumor with ulceration in the center, like a volcano. This had very specific value in diagnosing lymphoma. Other than that, the overall sensitivity was very low for gross diagnosis, and for biopsies, it was very high. So this is different polyps. They're all lymphomatoid polyps. And immunohistochemistry, this is a leukocyte common antigen is diffusely positive, suggesting it's a lymphoma. And the lymphoepithelial lesion, which is quite characteristic of a mild lymphoma, is seen in this case. So when you see abnormal mucosa, please take adequate biopsies. And if the lesion is looking submucosal, you can make that out using narrowband very easily. Sample the tissues by well technique so that you get submucosal, adequate amount of submucosal tumors. How do you stage and prognosticate? Staging is important to plan appropriate therapy because very early lymphomas can be treated simply with antibiotics. And very early lymphomas, you can use EUS. So this is a mini probe that can be used if it is very superficial, or a balloon-assisted echoendoscope. So this is a case of a Zollinger Ellison. You can see marked thickening of the mucosal layer due to parietal cell hyperplasia. It's not a tumor. You can see it's not black. Whereas this is a gastric lymphoma. You can see it is all restricted to the inner two layers. The muscularis propria is intact, so it's not spilled out. And these are some mini probe pictures. You can see very early mucosal disease, which can be, which helps to guide the treatment. So the Lugano and the Paris classification systems are used to stage primary GI lymphomas nowadays. And very early tumors, stage 1 is tumors which are, without any nodal involvement. So you have stage 1 mucosa and submucosa only involved. These are those tumors where one may consider eradicating Helicobacter pylori in the stomach or Campylobacter jejuni in the duodenum to achieve a response. However, when you have a diagnosis of lymphoma, PET scan would be an imaging of PET scan is it gives a whole total picture of the nodal spread, marrow involvement, etc. We will see some examples as we go by. Stage 3 and 4 are generally clubbed as stage 4, and they are generally part of a diffuse, advanced lymphoma. The risk stratification also uses the IPI and its modification, the IPI and the NCCN IPI, etc. This helps to grade and prognosticate lymphomas. Coming to the management, antibiotic therapy is recommended for very early mild lymphomas, which have not spread beyond the mucosa. And for all others, immunochemotherapy is the main treatment. So for immunochemotherapy, just a word about the B cells. which express the CD20 receptors on the surface, and by blocking those CD20 with a monoclonal like rituximab, it activates various mechanisms, the macrophage, the NK cell, the DC, etc., and causes destruction and causes severe depression of the immunity. So for gastroenterologists, please remember that rituximab is extensively used in management of both GI and non-nodal GI, non-GI extranodal lymphomas. And we must remember that these patients, if they have old hepatitis B infection, which is fairly common in old people of India, and they can flare because of extensive suppression of the immunity. And so we need to identify these patients and give them prophylaxis if they are going in for a rituximab therapy. The general principles of management includes, for a very few patients, who are very elderly, who have a low burden and indolent type, you can wait and watch. If the tumor is of mild type and early, one can try antibiotic therapy. Immunochemotherapy is generally used for almost 90% of all lymphomas, and it can be dose intensified in more aggressive forms, maybe dose intensified followed by transplantation in a few. Radiation is used for some localized disease that is not responding well to immunochemotherapy, and other forms of immunotherapy and CAR therapies are evolving. There are a lot of salvage therapies when first-line treatments fail, and surgery is used to treat obstruction, perforation, and bleeding. Just a quick run through some of the rare lymphomas and I'll be finished. This is an example of a mild lymphoma, but it's not in the stomach, but in the nasal mucosa, where I was involved in the management. This patient incidentally had a Helicobacter pylori. He was initially treated inadequately for Helicobacter. There was partial remission, but the tumor persisted and so did the H. pylori. Then 4-drug combination was given with eradication and complete regression, and the patient remained in remission for 2 years. And this is a nasal mild lymphoma, not a gastric, but probably he had some, bacterial antigens that was triggering his lymphoma. This is an example of a multiple lymphomatoid polyposis. This is a mantle cell type of lymphoma. It presents as multiple polyps. This patient had presented with bloody diarrhea. There were multiple polyps. You can see polyps in the stomach. There was a large tumor in the terminal ileum. There was a CD20 positive tumor. And this is before treatment, and this is after treatment, completely normalized. And the patient was well for 2 years, but these lymphomas are generally known to relapse after 2 to 3 years. And sometimes the treatment is consolidated with autologous bone marrow transplant. This is an enteropathy-associated T-cell lymphoma from, it was reported from Manipal. The patient had a usual presentation. 63-year-old female who came with intestinal obstruction was found to have a tumor, underwent a resection. You can see that this is a CD3 positive tumor. It's a T-cell lymphoma. And unfortunately, this patient had post-operative complications and succumbed to the disease. Because these T-cell lymphomas are extremely rare, there have been collaborative studies. This is a T-cell project across the world. Many centers were participating. And they found that about 4% of all T-cell lymphomas are in the enteropathy type, what we call the EATL type of GI lymphomas, which are common in patients with celiac disease. So these were the symptoms. Just 4% were above 60. That means it was more in middle-aged individuals. Most patients had these symptoms. All of them were advanced, 3 or 4. Bone marrow was involved in 86%. prognostic factors were very high. LDH was high, and the survivals were very low. 3-year survival, just about 30% of patients were able to survive for 3 years, and most of the patients were treated with chemotherapy with the anthracycline. These are some of the other rare types. This is from the Velour series. Patients who have had renal transplants on immunosuppressive, they go on to develop post-transplant lymphoma. These are some examples. Various sites, DLBCL as well as T cells. So the HIV infection, again, immunosuppression, putting patients at risk of developing again stomach DLBCL as well as some other types. I think I've come to the end of my introduction and we'll begin the panel discussion. So the first question is addressed to Prachi. Dr. Prachi Patil, as introduced, is a professor of gastroenterology at GMH Mumbai. So can we suspect lymphomatous nature based on endoscopic appearance? And what about the biopsies? What are your views? What is your recommendation to all the listeners?
I think the short answer to the question is no. We cannot suspect lymphomatous nature of a neoplasm from its endoscopic appearance, and the slide that you're showing demonstrates that well. And I'm probably repeating what you already said before, but I just want to emphasize that there is a huge range of lesions that can represent lymphomas, and there's no single diagnostic lesion. So at one end, we have these frank tumor-like appearances, which could be polypoid or ulcerated or stenotic. And then there can be thickened folds, superficial ulcers, or even harmless gastritis-like lesions, just some erythema or erosions. And endoscopy has also been reported to be normal in a small proportion of patients. Also, a lot of these patients are going to present with non-specific symptoms. So the endoscopist doesn't really have a diagnosis of lymphoma at the back of his or her mind while doing the scopy. So most of them are not suspected to have a lymphoma, are being investigated for likely benign conditions, and I think we can't just go by the endoscopic appearance. So a biopsy is absolutely a must because there is no standard endoscopic
What do you
appearance.
recommend?
So since histology is the gold standard, a structured biopsy protocol is quite important. And two things to remember is that these are tumors that can arise from deeper mucosa or submucosa. And also this can be multifocal, so sampling errors can happen. So I think we need at least 8 to 10 deep biopsies from any abnormal looking areas. At the same time, especially for gastric lesions, we need to have biopsies from the normal areas also to look for H. pylori. So 2 biopsies from the antrum, 2 from the corpus, 2 from the fundus, and also an RUT. It always helps to have the biopsies reviewed by a dedicated lymphoma pathologist. I think that's recommended by most guidelines.
Now, would you send all biopsies to the lymphoma expert or you leave it to the pathology person reviewing it?
So I would leave it to the pathology because I don't know that I'm biopsying a lymphoma when I'm doing a biopsy. But if on pathology there is a strong suspicion of a lymphoma, then it is good that a lymphoma expert sees it.
So what are the other uses in other than the diagnostic endoscopy where endoscopy procedures can be used?
So the most important indication is diagnostic, where apart from taking biopsies, it's also important to document certain things like deeply ulcerated tumors or very bulky masses. As in some patients, they may predispose to some complications on therapy. EUS is another place where endoscopy comes into play in the staging, especially for gastric lymphomas. So typically a very thickened wall is seen in a lot of lymphomas. You can have thickening of more than 10 to 12 millimeters also. And there are some characteristic EUS features which have been described. So it can be multiple types, like either a spreading type or infiltrating or a tumor kind of appearance. EUS has an importance in two things essentially, to prognosticate the tumors and to see who will respond. So the deeper the involvement of the wall layers in the stomach, the less likelihood of responding to H. pylori eradication in malt lymphomas. And also, if there are no lymph nodes seen, regional lymph nodes on EUS, then there is a high likelihood of eradication to H. pylori giving a good response. So EUS does not have any defined role in the follow-up as of now. Then there are a lot of patients who will come with obstructive tumors. So in these patients, we can put feeding tubes to improve their nutritional status, because chemotherapeutic regimens can also take a toll, and good nutrition is important. Just a word of caution about putting in metal stents in these patients, both before taking biopsies and even after taking biopsies, because these are tumors that respond well to treatment. So we have to be sure there's an MDT evaluation done before putting in stents. Some patients do present with obstructive jaundice because of nodal masses, but again, it's very rare that we need to step in and do an ERCP for these patients. Most of them will respond well to chemotherapy. Uh, Endoscopy, we are frequently called upon when patients present with bleeding, but it has a very limited role to play when patients present with complications like hematemesis.
Yeah, so this is an example of a large proximal gastric lymphoma causing stenosis at the G junction and dysphagia. So this patient, we put an NG tube and then the patient had chemotherapy, and you can see there's a complete resolution of the tumor. So NG tube placement is very useful, and NJ tube also can be placed in many patients who have distal gastric tumors. This is a patient who presented with obstructive jaundice. There is a lymphoma in the periampullary region. That is the US picture. There is a tumor in the inside the lumen, as well as a tumor outside causing biliary obstruction. And this patient actually underwent biliary stenting and then received chemotherapy. Okay.
So can I just also add a caution about using metal stents while doing a biliary stenting in these patients, because again, a lot of these tumors would respond well. So it's always a good idea to have a multidisciplinary team discussion and preferably put a plastic stent as compared to a metal stent.
Okay. Or a covered metal stent that can
or
be
a covered
removed.
metal stent which can be removed. Yeah.
Okay. The next question is to Dr. Rimpa. Dr. Rimpa is a senior consultant in radiation oncology at Tata Medical Center, Kolkata. And she is also the chief radiation oncologist in the lymphoma clinic. So Rimpa is covering for the radiologists as well. What is the staging, current standard for staging lymphomas? And is there any role to do bone marrow aspiration or bone marrow biopsy if a PET scan is done? And an interim PET scan as well.
So I think these are very important questions in context of the beginning of diagnosis and treatment for any cancer, and GI lymphomas are no different. And the discussion for staging has been well set by discussions on upper GI endoscopy and EUS, which just got over. And I believe that staging is important because that will dictate the treatment and the outcome of the patient. So as for any treatment, the first thing that a patient undergoes after an initial biopsy diagnosis is when they come to clinic to us or any oncology center, is a complete hemat and a biochemical profile. For the usual reasons, if there's anemia, you correct it. If there are derangements, you correct it. Correct nutritional indicators of hemat and biochemistry if needed. What is important for blood and biochemistry is a complete LDH and a beta-2 microglobulin for these patients, because LDH values and beta-2 microglobulins are prognostic indicators and predictors of outcome for non-Hodgkin's lymphomas. And largely, like Dr. Mohandas mentioned in his presentation, that in the correct scenario, apart from upper GI endoscopy and EUS and biopsies to prove the diagnosis, PET is emerging in a very big way. The 18-fluorodeoxyglucose PET is emerging in a very big way as kind of a one-stop shop for staging investigations. Although I believe that For our country, PET may not be available all over the country. And CT thorax, abdomen and pelvis with good quality contrast has been the standard of investigation for lymphomas. And to mention in context of PET, the sensitivity of PET varies across the types of GI lymphomas that Dr. Professor Mohandas has elegantly described. To the extent that the sensitivity of picking up the lower grade GI lymphomas like extranodal marginal zone or gastric mold is only to the tune of about 71% for PET. However, if we are looking at DLBCLs which have infiltrated the gastrointestinal tract, the sensitivity is up to 100%. So that is a very small snag in terms of PET being used as the single investigation for lower grade tumors. However, most centers have now adopted PET, and the staging has also been discussed, is the Lugano or the Paris system of staging. They are very similar. The only advantage of the TNM classification, which is hardly ever used. So the Paris is mostly based on TNM, and that just identifies the thickness of the gastric wall, which is a future responder of anti-Helicobacter treatment for moltomas. So I thought I would mention that in the passing for the staging investigations. Apart from investigational staging, as a clinician, it is very important to examine the oropharynx correctly, because there are situations where a finite percentage of patients may have involvement of the Waldeur's ring in association with lymphomas involving stomach or other parts of the gastrointestinal tract. And as the picture, as the slide is shown by Dr. Mohandas, PET or metabolic investigations gives a global overview of extra gastrointestinal disease in terms of nodal involvement, pharyngeal involvement, or any other. And the other staging thing is our cytogenetic studies. Often we as radiation oncologists have an important role to play in very limited stage moltomas or extranodal marginal zone lymphomas of the stomach. I keep mentioning stomach because stomach is the commonest site where we see these lymphomas in, as was shown by Dr. Mohandas in his presentation slides. And a T1118 translocation usually dictates the non-Helicobacter patients. So Helicobacter pylori staining, the standard stains of Genta, Wadden, Sturry, etc., or even serology in about 10% of patients with Helicobacter infections could be a start, or most often is a part of the staging workup to have a bearing on the treatment, because often for very early stage Helicobacter associated moltomas, radiation oncologists would say that give a trial of anti-Helicobacter and majority of the patients would clear out, and you don't have to treat these patients with ionizing radiation. I think that's the standard approach. Now, coming to the second pertinent question of bone marrow investigation, I would just cover that by saying that, again, for the low grade tumors like extranodal marginal zone and moltomas, which may not be FDG avid, if there is a suspicion of advanced disease, please go ahead with the marrow biopsy. For DLBCLs, PET is gradually replacing the use of investigation like the bone marrow biopsy, and it is a very sensitive investigation to pick up bone marrow disease. I think if there's anything else, Dr. Mohandas, that needs attention.
Rimpa. We'll move on. If there are other questions, we'll take them up at the end. So the next question is to Professor Naveen Khattry, who is a medical oncologist, and he heads the bone marrow transplant program in TMS Mumbai. So what are the importance of prognostication of patients and the role of MDT in improving outcomes? I showed in the beginning the results of survival results of lymphomas in India are pretty bad. So will MDTs help? And nowadays you have EMDTs. You have experts all over the country or world who can participate. Very often we reach out to Ranjana Advani in Stanford. She has been extremely supportive to many of us. So what are your views on that?
Thank you, sir. Firstly, thank you for giving such a simplistic overview of a group of disorders which is complex to even hemato-oncologists like us. It was a phenomenal lecture, sir. Very simple, very nice. Now, coming to that question of prognostication, you know, in lymphoma, the simplest has been the International Prognostic Index, which was conceptualized way back in 1993, 1994. And it just has 5 clinical factors: age, LDH, staging, and then the extranodal site involvement, and the LDH. Now, in this 5, with these 5 factors, we were able to prognosticate. However, the problem arose when rituximab came into the treatment armamentarium, and with that, the overall survival of all lymphomas started improving significantly. So then this lost its significance and came the revised IPI, where revised IPI meant that in the rituximab era, the stratification slightly changed, but those 5 factors remain as the prognostic factors. Now the NCCN IPI is a modification of that, because age in the IPI was 60 and above. Now we all know that lymphomas have different prognostication according to age 40 to an age 75 or 80. So the NCN IPI actually further discriminates with the age, and you have 4 groups: 40, 60, 60 to 75, and above 75. And it also further stratifies the LDH. In the IPI, it was broad, it was only upper limit of normal, but in the NCN IPI, it was further stratified to more than 3 times the normal or less than 3 times. With this, the discrimination has improved, and now you will see that with the NCCN IPI, you are able to discriminate the best group versus the poorest group, but this is also not adequate, because even with the NCCN IPI, most patients in the worst group also have survival of around 50%, which is actually not true, because it's not like taking into account the molecular stratification. So right now, in a nutshell, NCCN IPI is probably the best discriminator, but more needs to be done by adding the molecular signatures, as you have suggested, 11, 18, and 314, and so forth, so on and so forth. Now, as far as MDT is concerned, I think in every disease, every cancer, MDT forms a backbone of treatment strategy. In our hospital, the Tata hospital, the MDT for lymphoma, as sir you would know, started in 1987-88 with Dr. Advani and Dr. Dinshaw. And that has led to, I wouldn't say that, you know, I would not have the hard facts of how the survival outcomes would have improved, but it certainly helps in managing patients, because you have a radiation oncologist, a medical oncologist, a pathologist, and for GI lymphomas, a gastroenterologist, who will then sit and decide upon the treatment strategy. Lymphomas are heterogeneous. What may appear like a diffuse large B cell may actually be a malt lymphoma or a mantle cell, depending on how good a lymphoma expert is there in pathology. So this certainly helps, and that I think most of us will agree it helps.
So Naveen, your next question is, briefly tell us about the principles, employed in treating, managing GI lymphomas, and how, the different subtypes, basic, simple differences, because we don't have too much of time. So if you could do that.
So Prachi and Rimpa have already discussed about the nutritional aspects, so I'm not going to go to that. I would straight away come to how do you treat one versus the other. So the easiest, I think, for the gastroenterologist will be maltomas, because the gastric maltomas, the best treatment is to give the H. pylori treatment and then wait and watch. They are low-grade lymphomas. Even if you don't do anything for some time, it's not going to cause a major problem. The important is the diffuse large B-cell lymphoma, and that has to be treated just like a diffuse large B-cell of the lymph nodes. So you give 6 to 8 cycles of rituximab based chemotherapy, and the standard is CHOP. Many of us would have heard that That is the standard treatment with rituximab. Now, what is very important is you need to check for chronic hepatitis B before starting rituximab, as you have just mentioned earlier, because that will lead to the flare of hepatitis B. Now, for mantle cell lymphoma, again, it's rituximab based with addition of cytarabine, which is a very important drug for mantle cell lymphoma. IPSIT is predominantly, again, antibiotics, tetracycline or metronidazole for few months. And if it doesn't subside, then of course, chemotherapy. The worst is the entropathy associated T-cell lymphoma. We certainly have a long way to go to have a good treatment for that. Presently, CHOP seems to be the drug regimen, but there's a lot more to do for that group of lymphomas.
So has any of the panel members, anybody has seen more than 5 MLPs or ETLs in their career? Just to get an idea how common this disease is. Rimpa?
So I haven't seen more than 5 EATLs.
Naveen?
So since we have a huge tertiary center, I think over the last 10 years, I've seen certainly more than 5 of both. But again, as we know, it's rare and the prognosis is very poor for the EATLs.
Regarding the MLPs, would you consolidate chemotherapy with transplant? Because these are mantle cells and are always prone to relapse within a few years.
So it depends on the age and the performance status. If the patient is of a younger age, less than 60, and with good performance status, there is enough evidence for mantle cell lymphoma that doing transplant in first remission probably has the best outcomes. So yes, these are the mantle cell lymphoma patients who probably should undergo transplant in the first remission.
There is an emerging view also that in patients with celiac disease, if you catch the very early stage of ETL, you can subject them to transplants, autologous. You have any knowledge about it?
Yes, sir. The only problem with the EATLs is, that, by the time the patient presents, the patient already has a significant history of malabsorption with, with the performance status not being great. Having said that, you have young patients with good performance status. One can certainly uh, take these patients for autologous transplant, but the T-cell lymphomas don't do as well as the B-cell, even with auto transplants. So the prognosis will certainly be more guarded than the B-cell. Mantle cell is a B-cell. This is a T-cell lymphoma.
Thank you, Naveen. We come back to Rimpa. Rimpa, what about the role of radiation therapy in the management of GI lymphomas?
Yes, so like we saw that the GI lymphomas are a very heterogeneous group involving a number of diagnoses. And as for radiation oncology for any indication, the treatment can either be with a curative intent or it can be a palliative intent. And palliation can be endoscopic procedures, it can be palliative chemotherapy or palliative radiation mostly for obstruction, because we don't usually use a lot of radiotherapy for active bleeds for lymphomas, although there is a niche indication there. So the palliation is a different ballgame. Now coming to the curative aspect, radiation can either be used alone for very niche indications like very early stage 1 and stage 2 extranodal marginal zone lymphomas of the stomach or gastric or intestinal maltomas, or it can be integrated with combined chemoimmunotherapy, mostly for early stage bulky disease, DLBCLs. Because the moment there is advanced stage in DLBCL, although there is a role of radiation therapy for improving prognosis-free interval, it doesn't impact OS. So to have a very simple algorithm, radiation therapy for GI lymphomas, curative, palliative. Palliative for palliation of symptoms, curative as single modality for early stage low grades, and as a part of combined modality treatment for diffuse large B-cell lymphomas of the GI tract of limited stage.
You know, since many patients with lymphomas will get cured and will have a very long life, what about the long-term side effects of radiation therapy to the GI tract? You want to just say a little bit
Oh,
about
of
that?
course. So the advantage of being a lymphoma radiation oncologist is that lymphomas are exquisitely sensitive to radiation therapy, and therefore the doses required for eradication or local control that impacts the overall survival is less. So you know, sir, that for lymphomas of the lower grade like maltomas, a dose of 25 to 30 gray is more than enough to achieve a 90 to 100% overall survival in these patients, and so is it for extranodal. The only problems with using low dose would be slight anorexia, nausea, vomiting. These are acute effects which can be handled on outpatient basis with supportive care. Slightly higher doses are used for DLBCLs or in certain very selected cases of salvage for refractory disease. There we could have some problems like telangiectasia, GI bleeds, subacute obstructions. But if handled well, I mean, if organ tolerance or renal tolerance is well respected, the GI and the kidney, which is often the organ of risk in the abdominal radiation, is well handled. So there's nothing to fear with good use of radiation oncology.
Thank you. Dr. Naveen or Prachi, what would be the optimal follow-ups? Because these are patients who achieve complete response. A large majority will achieve complete response, and then you are wanting to look for relapses that may happen for a period of time. So would you repeat endoscopies, imagings? How do you follow up these patients?
Endoscopy probably has a definite role in the gastric lymphomas. Two situations. One is malt lymphomas, where we will confirm the eradication, and this scopy will be done at least 6 to 8 weeks after the patient has started on anti-H. pylori treatment. And we have to be sure that the patient has been off PPIs for 2 weeks and off antibiotics for about 4 weeks. And again, a similar meticulous biopsy protocol where we sample all possible abnormal areas is important. And the endoscopy is repeated 3 monthly in patients with malt lymphomas of the stomach until the patient has a complete response. And this has to be documented on 2 consecutive scopies, either a complete response or a minimal residual disease. And there are standard pathological definitions for both. And once the patient does have a response, then an endoscopy 6 monthly, at least for the first 2 years, and then annually. In patients with DLBCLs of the stomach, an endoscopy can be done 6 monthly, again for the first 2 years, and then annually thereafter. An important thing is that patients with malt lymphomas also are at an increased risk of adenocarcinomas of the stomach, almost a 5 to 6 fold increased risk. So while doing follow-up scopies, one should also be looking for early gastric cancer-like lesions. But again, we know that we need to do surveillance, but for how long, that is something that's not really definite. I don't think there are any guidelines for surveillance of patients who have endoscopic surveillance of patients who have either small intestinal or large intestinal lymphomas. Naveen, do you have anything to add?
No. That's...
So this, I think, is my last question to the panel for want of time. And that is, once the tumor relapses, or sometimes in a small percentage in whom there is no complete remission, there are a lot of salvage therapies which have evolved in the last decade. So Naveen, can you tell us something about that, and also the role of BMT checkpoint inhibition as well as CAR therapy? Briefly, what a gastroenterologist should know.
So just broadly, all the salvage therapy is probably best for diffuse large B-cell lymphoma because they are aggressive, and T-cell lymphoma. For maltoma, you really don't need such intensive salvage therapies because they still do well even with gentle treatments. Now for DLBCL, BMT is the...
It's 1 o'clock.
Hello?
No, carry on.
So the BMT is the best salvage therapy after giving some chemotherapy for those who relapse after a diffuse large B-cell lymphoma. Checkpoint inhibition in diffuse large B-cell lymphoma is not as good as in Hodgkin lymphoma and some other lymphomas. So it can be used, but that's not the best treatment. CAR T cells certainly in those who fail after transplant, because there is emerging data that CAR T cell is good for diffuse large B cell lymphomas. And what CAR T cells means is that you develop your own T cells which are targeting those B cells which have the cancer. Now for maltomas, one can use salvage therapies like radiation and even rituximab based if they fail to antibiotics. So basically maltomas are low grade, so the intensity is low grade. B cell, DLB cell is aggressive, T cell is aggressive, so your salvage therapy also has to be aggressive, provided the patient is fit to undergo those salvage therapy.
Can you just add a very brief comment on the cost of therapy of patients? Because that's something that we don't bother about. We start our patients on treatment and halfway down the line they give up treatment, and that's one of the reasons why we have poor outcomes.
Yes, sir.
So can you, the cost and the length of treatment that doctors should be telling their patients upfront.
So initial upfront therapy for aggressive lymphomas like DLBCL is the treatment is R-CHOP, 6 to 8 cycles, and that usually takes around 3 to 3.5 lakhs, because the most expensive drug in that is rituximab, which is around 28 to 30,000 per cycle. When they relapse, then transplant comes into the armamentarium after some salvage chemotherapy, and transplant could be anywhere from a government hospital like AIMS to around 2 to 3 lakhs to our hospital and your hospital to around 5 to 6 lakhs just for transplant. As far as CAR T cell is concerned, well, no center in India has started. We will certainly start maybe in the next 1 year. We don't know what the cost will be, but it will certainly be in lakhs. So that's, again, out of the reach of most of the patients. Checkpoint inhibitors, again, it's expensive right now, and it could be anything between 5 to 8 lakhs for at least 3 to 6 months. What we need to remember is that checkpoint inhibitors may have to be given till progression. And I don't think any section of our society except the ultra rich who can continuously take the checkpoint inhibitors till progression. So that again, only in a clinical trial you'll be able to get patients.
Okay, thank you, Naveen. So to summarize today's discussions, I would like to say that GI lymphomas are not uncommon, provided we look for it, and which means that there is a adequate biopsy is necessary. The GI lymphoma is present in various ways and they masquerade, and therefore there is no real way of knowing when you first see the patient or first do the endoscopy as to this is a lymphoma, and therefore taking multiple adequate biopsies, which Prachi had explained so well, should be carried out. The tissues must go for immunohistochemistry, and I would, most medical colleges are still, we find reports not having ISGs. Sometimes the tumors are reported as poorly differentiated carcinoma, and then we re-biopsy and do ISG and find it's a lymphoma. So those kind of things can be avoided if at the initial go itself, simple immunohistochemistry, which can be carried out everywhere, is done. I mentioned about the malnutrition and cachexia being a poor prognostic factor, and a lot of GI lymphoma patients have it, and that should be addressed by the gastroenterologist from the very beginning. For high-grade lymphomas, PET-CT is the one-stop staging. For low-grade, of course, the sensitivity of PET-CT comes down. Therefore, it's a good idea to wait for the biopsy, have the biopsy report come, and then order the appropriate scan, because I find that sometimes neuroendocrine tumors again. So patients get multiple CT scans, MRI scans, when actually for neuroendocrine, they need a finite nota scan. For a high-grade lymphoma, you need a PET scan. For a rectal cancer, it may be just MR pelvis with a CT scan of the chest and the upper abdomen. So instead of duplicating and wasting the money of the patients, one should wait for the biopsy report before the appropriate scanning is performed. Early mild lymphomas can be cured by antibiotics, and so this is entirely within the purview of the gastroenterology. You need to look at, when you find small lesions, you need to biopsy them, confirm that they are early mild lymphomas, and then they can be treated with antibiotics. Immunochemotherapy forms the main workhorse against treatment of GI lymphomas, and radiotherapy and surgery are needed in a select group of patients. And even if the patients relapse, there is a large set of patients who relapse who can be salvaged. Many of them can be even cured by other treatments that we have discussed during this panel. I have included some references here. These are, the first is Professor Kugli's group's paper in PMJ Open. This is an open access. The patterns of GI lymphomas from Vellore. And this is, of course, the National Management of Lymphoma Consensus. It's an Indian expert group. This is very appropriate. In addition, if you want, there are, of course, hundreds of guidelines available from NCCN and onwards. But I find the ESMO, which is the European Society of Medical Oncology, to be the most practical for a country like ours. And they have various guidelines, including pocket guidelines are there. So one could, refer to that. So now we can open the meeting for question and answers. I'll close my presentation so that I can see what is happening.
Well, thank you very much, Professor Mohandas. I think it has been superb and a masterly overview in a very limited period of time of the entire gamut of presentations and problems that one faces with GI lymphomas. And you, as well as the panel, have really been able to give a very concise and overview. There have been a lot of questions on the chat box. About 35-40 questions have already come in. And maybe we can use the next 20 minutes or so to cover some of these questions. Dr. Simna from Trivandrum wants to know what is exactly the difference between the Lugano and the modified Paris staging for primary GI lymphomas, and how do we use them? So maybe somebody.
Shall I take this? Yeah.
Yes,
so,
Naveen.
In practical sense, no one uses the TNM staging for lymphoma. It's the Lugano staging, which has been simplified from the previous staging of Ann Arbor and their modification. So the Lugano staging is very simple, and it tells you whether it's localized to the organ for extranodal, whether the lymph nodes locoregionally have been involved, or whether it is spread to other extranodal regions which are distant. And that's the way, that's probably the easiest way to stage, because the treatment actually will only depend whether it's localized or it's distant, whether it's widespread. So the TNM staging may be more important in solid cancers, not in hematolymphoid cancers as per se. Until unless you're looking at the endoscopic ultrasound and then looking at the mucosal and submucosal involvement, which may have some prognostic relevance, but to be honest, in the broad base, it probably will not make too much of a difference.
And the Paris modification and the Paris staging, how does it add to the Lugano?
So that's what it is. The Paris staging is the TNM, the tumor size, the node, and the metastasis, right, which is predominantly for solid tumor cancers. It doesn't have significant relevance in lymphomas per se. Right. So in order to not confuse the students of gastroenterology in this meeting, I think Lugano staging is very simple. That's probably the best to use. And even our students, we recommend them to use this.
Right. Dr. Bhavesh from Lucknow wants to know why B-cell lymphomas are so much more commoner than the T-cell lymphomas. 90% versus 10%, what you had said. So any thoughts on that?
Sir is the epidemiologist. Sir, could you answer that question?
I don't know. Probably the B cell load is, if you apply Vogelstein's hypothesis, then one would think that there are more B cells in the body than there are T cells. That could be one, but something called Peters paradox. Elephants and whales don't get cancer, although they have millions of more cells than other animals. So if you assume that the number of cells, large animals get cancer, small animals don't get that many cancers. And the animals that live very long get more cancers as compared to those who live, because these mutations happening in the stem cells are happening at random. So I have no idea as to how this is more common, but in terms of numbers, the load of T cells and
Right.
any of the hemato-oncologists.
It's one of those things that it is just the way we can have explanations or offer possibilities, but it's very difficult to be very sure on these things. I think in continuation with this, I think there's a question on the so-called Indian paradox, that you have such a lot of H. pylori infection prevalent in this country, but compared to that, gastric cancer, gastric lymphoma is not all that common. So again, any thoughts on why this is so?
So it started off as the African paradox, and then it ended up as Indian paradox. The original H. pylori gastric cancer was mentioned as an African paradox, because there's a lot of H. pylori but very little gastric cancer. There are several reasons. One of them is that the average life expectancy, the COVID paradox also, it is the same. The average life expectancy is less. Italy has 26% of the population above 60 years of age. India has just 10%. If COVID is killing all people, the old people, obviously more will die there than in a young country. So in India also, if you see Uttar Pradesh and Kerala, in my paper I've shown very clearly the age difference of the pyramid. In Kerala, there are many more old people, so more cancer is there. So that is one of the things. Secondly, a lot of low-grade lymphomas are not diagnosed because endoscopists are not taking adequate biopsies. Typically, you go to a busy medical college hospital, you will see endoscopy is being done in 2 minutes, 3 minutes. That is the time taken. I'm being very critical on the national meeting because that's not the way to do it. If you go to Japan, each endoscopy takes 40 to 45 minutes. They wash every nook and corner, and then they take biopsy. So you diagnose lesions earlier. I showed you that 2/3 of our PI lymphomas are very advanced, which is not the case of ours. So those things are all contributing to the survival, the incidence, etc. In addition to this, there is also a very interesting theory, which is about the presence of elements in the GI tract. The elements modulate the T lymphocyte responses, immune responses, and there have been very elegant studies done in mice published in Nature. Mice with H. pylori infection, if they are also exposed to elements, they get cancer because the progression of the atrophic gastritis, gastric dysplasia, that pathway is completely altered if the gut T cells are being modulated by the elements.
Yeah.
And urbanization is something that causes elements to disappear from the gut. Associated disease, Crohn's disease, number of other diseases also seem to be increasing as elements are disappearing from the agenda.
Dr. Mohandas, your voice is not coming very clear. I think, are you too close to your mic or something?
Some disturbance. Anyway, I think this is a long topic that will probably merit separate discussion also. So I think we can probably move to some of the other more practical questions. I think Dr. Prachi mentioned clearly about how to take biopsies in people with suspected lymphoma. At the same time, you did mention that it is actually endoscopically not possible to be sure that there is going to be a lymphoma. So in practice, what you're suggesting is that in every suspected cancer or lesion that appears malignant, you must take about 8 to 10 pieces and
Yes.
also sample the corpus, the body, and the fundus, RUT, all that in every patient with the, say, a gastric lesion that looks
So
could be a cancer?
yeah, so this is what is recommended in every patient, but unfortunately, we don't really know who is going to have a strong suspicion of turning out to be a lymphoma. So typically what happens is that these protocols are followed up often at the second endoscopy. So someone comes with a biopsy suspicious of a lymphoma, sent for a repeat scopy, and then you have the then you can probably do a very detailed staging and do a detailed biopsies and all that. But very often the index scopy is, you will approach it like you would approach any other patient with gastritis. So this kind of a thing
Exactly.
is frequently at the second scopy and not really at the index scopy.
Yeah. See,
I,
that's
I
an
just
important
want
point.
to add that even for gastric adenocarcinoma, you must request the pathologist to look for features of Helicobacter in the
Yeah.
resected
Right.
specimen margins, and you must eradicate it to prevent relapse. There are randomized trials, meta-analysis showing that H. pylori eradication reduces gastric cancer. And now gastric cancer has become the fourth leading cancer in India. So it is not rare anymore because Indians have become older and are now getting, the long effects of gastric cancer.
Right.
Sir,
Right.
if I can
Non-fatal
add,
gastritis.
I mean, if it is so, if the change in epidemiology of gastric cancer in our country was the last 20 or 30 years, and now gastric cancer being the fourth important cancer, GI cancer, then this of course, question also become very relevant, which we discussed just now, that H. pylori and gastric cancer, is it still a paradox? So I think rather than closing the story here, that is a paradox, I think we should keep our mind open and thoughts open, that we may not be right what we've been thinking. There may be a new thoughts there, and probably we require
We
more
need
science.
more information. I mean, this
Yeah.
is a thing under construction. It's not a complete picture as yet.
So from taking from one of the old Western movies, I like to say that the only good H. pylori is a dead H. pylori.
Very good.
Right. Okay, moving on with some of the other questions. I think you mentioned about rituximab and hepatitis B preemptive treatment may be needed. So Dr. S.K. Sharma from New Delhi wants to know if a person, how often is tuberculosis and or HBV seen in these people with GI lymphoma? And if so, what should be the optimum duration of antiviral therapy or anti-tuberculous therapy given before you start chemotherapy for lymphoma? You are muted, Dr. Naveen. Could you unmute and Naveen? Yeah, that's better.
So not only for GI lymphoma, the answer is actually, the question is for any lymphoma. Now, hepatitis B is prevalent in our country, and the gastroenterologist will know more than me, but what is the incidence of hepatitis B, the chronic hepatitis B? So for those who are having lymphoma and need rituximab, they must get the HB-core IgG done and the other anti-HBsAg and HBsAg done. And if there is chronic hepatitis B, then they must be on an antiviral for at least 2 to 3 weeks before they can be given rituximab, but they can be given other parts of the chemotherapy because they will probably not have a major role to play as far as flare is concerned. So that's for the rituximab. For tuberculosis, unfortunately, again, the incidence of TB in India and the endemicity of TB, it is not easy to tell you exactly what you would do. But if you have TB, which is occurring together with lymphoma, I don't know whether that happens usually. Some people would have already had tuberculosis and then they may have lymphoma, or after you start the treatment for lymphoma, then you develop TB. So basically, there I don't think there's any major issue regarding starting the ATT as well as the chemotherapy for lymphoma. You only would need to look at the drug interactions because some of the drugs may be underdosed and some may be overdosed. There I'm not sure that one would really wait till you start treating tuberculosis because lymphoma is also as aggressive as tuberculosis. It is predominantly for rituximab that we need to give few weeks of antiviral before you give the rituximab.
Right.
So I just can add a bit. When we started here in Kolkata, we were not routinely screening all our patients for total core antibody. And we had 4 patients who had fulminant hepatitis flares. They were all HBsAg negative, and the initial screen is, a screen for HBsAg, anti-HCV, and HIV. So they were all negative, and these patients, 4 flared, 2 patients died of fulminant hemophilia. Since then, I'm going by the world guidelines. We started now doing routinely core antibodies, total core antibodies for all our patients. And let me tell you, 13% of the patients who come to my hospital are core antibody positive. So the population prevalence of core antibody positivity is very high. Cancer patients are all old people. They are not immunized, they are all pre-vaccine era patients. And so they are all at risk. And so we have to screen all patients who are undergoing long chemotherapies, immunosuppressive therapies for flares.
All core antibody positive patients are advised preemptive antiviral therapy?
If they are getting highly immunosuppressive
Yes,
therapies like that.
planned.
Yes.
So rituximab is also used in many non-oncology settings, like it is used in, I think, arthritis and some ophthalmology situations, so many places. So, you will have patients who may flare, and so keep a watch.
Right. So that is useful information. Dr. Shankar Barai from Nepal wanted to know what should be the duration of antibiotic treatment for a patient with early IPSID?
So IPSID is really, really rare. I think very, very few, even the biggest series show like 3 to 4 patients seen over a period of 10 years. But what is recommended is, I think, an antibiotic combination, tetracyclines with metronidazole, and you need to give it long term, 3 to 6 months. And I think if there's no response at the end of 6 months, then maybe the medical oncologist would consider chemotherapy.
If I can have a word out here, so in our clinic, at celiac clinic, we have about 12 patients with IPSID following. And very interesting, 2 observations. One, that number of patients who received renal transplantation, and they are referred to us as a chronic diarrhea, and we find some of them have a IPSID. So my question was, I planned the question to you also, that the post-transplant lymphoproliferative disorder, the PTLD, and IPSID. So are the 2 different things, are the spectrum of 2 different spectrum, that post-transplant, especially renal transplant, and we see patients at the stage when they have a IPSID stage, and then well described as a PTLD. So are the same spectrum?
For IPSID, they need to be producing alpha heavy chains. So
how do we confirm that? We don't have
by
to confirm.
electrophoresis. Yeah. So only if that is present, you would call it IPSID. Otherwise, it would be one of the other B lymphomas of the.
So alpha heavy chain in the jejunal fluid, not in the bloodstream.
So, sir,
in the jejunal, it is a little higher, but you can do it in the blood also.
So, the PTLD classically are EBV driven. So, the post-transplant lymphomas, whether it's to solid organ or to the bone marrow transplanted, are EBV driven. So if you do the blood EBV PCR, mostly you will get high loads of EBV PCR. It does not have any prognostic connotation, but it may help. The IPSID is basically the alpha chain disease where, as Dr. Mohandas has already said. So, the treatment may also be a bit different between the 2. And the IPSID may respond to the to antibiotics. The PTLD will not respond to the antibiotics because it has got nothing to do with Campylobacter jejuni or any of the other microorganisms. It's an EBV-driven lymphoma.
Right. Okay. I think continuing with there's a lot of interest in IPSID because people, at least a gastroenterologist, read a fair bit about IPSID. So Dr. Gautam from Udupi wants to know, this appears to be a slightly hypothetical situation, that if a person has a diagnosis of IPSID in the small bowel as well as H. pylori is present, can the IPSID be related to H. pylori, and can this patient be treated only with anti-H. pylori therapy?
So this is, I think it's an anecdotal kind of a question. So generally, if there's any lymphoma with H. pylori positivity in the stomach, there's definitely no harm in doing an H. pylori eradication therapy. However, with a proven IPSID, I think it would be judicious to also give the standard antibiotic treatment for IPSID, because if the patients do not respond, they may have to move on to chemotherapy.
Okay.
So I presented a nasopharyngeal marked lymphoma that responded to H. pylori therapy. Actually, if you see the literature, there are lots of mild lymphomas at other sites, salivary gland, lacrimal gland, and there are many anecdotal cases where eradicating H. pylori has caused permanent regression. In fact, that was the reason why that particular case we chose to eradicate H. pylori, and we also were surprised. We don't know if there is some other infection which was sitting there driving that, and the same antibiotics worked on that, infection, and therefore, or it is a remote control by H. pylori all the way from the stomach to the nose or to the lacrimal gland and so on and so forth.
Right.
I remember
Till this link
Desai
is
used to
well
talk about H.
established.
pylori in the oral cavity. He had lots of papers on it. So there could be H. pylori in other places.
But I mean, still this link is well established, and the response also established. It may be prudent to do what Prachi suggested, that if you have a proven IPSID, so treat for that as well as for H. pylori. Yeah, right. So I think in relation to your the comment on HBV, Dr. Naveen, Dr. Amit Yalsangikar from Bangalore wants to, his question is that with the increasing use of azathioprine in inflammatory bowel disease, reports of lymphoma in the colon are also increasing. Can this be prevented, and is there a role for EBV testing before initiating thiopurine treatment?
It's a difficult question. You know, there are lots of immune suppressive drugs used for various diseases, and many of them may be associated with increased risk of cancer. Having said that, you wouldn't do an EBV PCR to look for whether there is a EBV reactivation before giving treatment, because, you know, if you look at number of patients who receive, say, azathioprine, and the number of patients who then develop a T-cell lymphoma, the percentage is not significant. What we need to understand is that we need to keep a close watch, and if there are some vague symptoms also which develop, one needs to identify the cause of it and then diagnose it and then treat it. But I don't think you can, you know, do an EBV PCR for all patients who will go to infliximab or to thiopurine to do that, because there are many more immune suppressive drugs which are coming on, and they'll be used for various malignant and non-malignant disorders.
So we are coming to end of our time now, so it's almost reaching 1:30. Can I ask one question? And it's a question is a relevant from the country perspective, that especially those maltomas, and we are treating H. pylori, the eradication rate of H. pylori is to be confirmed. Now, the drug which we use in our country is clarithromycin, amoxicillin, and PPI. PPI is not a problem. Amoxicillin is not a problem, but the problem is now with clarithromycin. Clarithromycin resistance is increasing, and there are pockets in our country where 40% of people are resistant to, or H. pylori are resistant to clarithromycin. Therefore, writing a prescription that I'll give 2 weeks of antibiotics and PPI, and think in mind that we have treated H. pylori in maltoma is not confirmed. We need to confirm the H. pylori eradication at end of treatment. And even my own experience, we are treating 3 patients simultaneously, and in 2, even after 2 courses of anti-H. pylori treatment, there is H. pylori. And after 1 course of antibiotic, the lesion improved, but the lesion again started worsening. So for all us to understand, writing prescription of H. pylori in our country is not enough. We need to really confirm that we have eradicated effectively this. And we will have our own guidelines coming up, which is led by Dr. S.P. Singh, that Indian guidelines on H. pylori, and there we flag a very important issue of emerging clarithromycin resistance, and we have to have an alternative strategy. And one good thing, I think all of us we want to say that now bismuth is now getting available in our country, so we might have to use bismuth-based therapy in many patients with H. pylori. And my last question to maybe the panelists, that if you have a maltoma and you have eradicated H. pylori and the lesion have regressed, what is the protocol for follow-up of these individuals? And this question has come from Hari Prasad from Indore.
Yeah, I think Dr. S.K. Mishra and even Dr. Jayanti from Chennai have the same question. So I think it does need a comment from the panel.
So, Prachi, you want to take that?
Post eradication, I think so. Eradication has to be confirmed on 2 consecutive endoscopy and biopsies done 3 months apart. And following that, 6 monthly endoscopies for the first 2 to 3 years, followed by annual endoscopies. And again, to look not just for a MALT recurrence, but also to look for early gastric cancer-like lesions.
And this is a very important point that many people believe that maltoma once treated forever. So all these patients have to be kept into surveillance program and very frequent surveillance.
I think I just can't resist this last question from Professor Jung Delavri in Chandigarh. He also wants to know why gastric lymphomas is so common, although stomach does not have many lymphocytes. So getting a lot of philosophical questions, Dr. Mohandas. Why cancers here? Why cancers there?
So if you see, the new treatment in cancer is immunotherapy. You know, the big thing in cancer therapy is immunotherapy in the last few years. And if you see the GI tract, the biggest immune protecting mechanism lies anywhere just from duodenum all the way down. The stomach, because of its own functions, have very little, lymphoid tissue. So it is a little less protected as compared to small bowel. You don't see cancers. They are if you take in terms of surface area of the mucosa, small bowel mucosa is so big and it has the least amount of cancer, but it is full of immunotherapy. That's full of Peyer's patches and lymphoids around. So they don't really get malignancies, don't develop so easily in those cases. I think that's the reason.
Okay.
So keep H. pylori away and.
Wonderful discussion. I think Govind, I'll have hand over to you now. I think we have about 55 odd questions still remaining from the panel, which I think we'll follow the usual practice, maybe Dr. Mohandas, of sending the unanswered questions, about 30, 35 of them to you, and maybe you or some of the panel could help out. And if these answers that you provide will be then put up on the website along with the recording of this session for the participants to look at the answers to their questions. Okay, and with that, I'll hand over to Dr. Makharia.
Thank you very much for a wonderful talk. And I think this is more than what we expected. All the important point regarding when to suspect, how to achieve diagnosis. A very important point raised that you must take multiple biopsies while you suspect lymphoma, and again do all the proper staging of treatment. Again, we know that many lymphoma effective therapy and one can treat. And one last word, that H. pylori, please confirm if you eradicate H. pylori, especially in those lymphomas, and all these patients will require a very active surveillance. With this, I need to thank Dr. K. Mohandas, who made such a nice lecture,
really nice.
overview, and also led the panel discussion in a very relevant point he raised in the panel discussion. Thank you, Dr. Prachi, for a wonderful discussion. Dr. Naveen Khattry, and Dr. Rimpa Basu Achari. Thank you all so very much, and it has been such a pleasure. So the galaxy of our panelists, and they are all very well known in their own field, and coming and speak to us in a Sunday daytime. This is the family time on Sundays, but again, all of you spend almost 2 hours, and sometimes yesterday also while doing a trial run. Thank you so very much. Thank you, Dr. Saraswat, for again taking lead into master classes. Thank you all the viewers for watching these classes, and these classes have been put into ISG website. One can view them as you want to. And also all these masterclasses are recorded into the ISG page on YouTube too. For the next week, we will have one other panel discussion, and this will be second on the masterclass cancer series that will be on gallbladder cancer, and this will be led by Dr. V. A. Saraswat. He will lead the discussion on this topic on the next Sunday, that is September 6th. And the panelist would be Dr. V.K. Kapoor, who is authority on gallbladder cancer, published a lot of paper, and he will be a surgeon as a panelist. Then we have a Dr. Bajal. He will be, again, everybody knows he will be intervention radiologist in the panel. We will have Pravi Rai as a gastroenterologist and Dr. Atul Sharma as a medical oncologist. So we'll have a panel of 4 led by Dr. Saraswat. And Dr. Saraswat already identified many relevant points which he's going to highlight while we treat gallbladder cancer. I want to also tell that ISG abstracts for ISGCon 2020 are open. So please do submit your abstracts and full papers for young investigator and plenary session. With this, have a nice Sunday, and we see you again on September 6th. Have a great day, and bye-bye, everyone.
Thank you.
Thank you very much. Thanks,
Thank you.
everyone. Bye-bye.
Thank you, sir. Pleasure.
Thank you.